How's that?
I can see you now. You last thing I heard is you said you put one perk close down, use the wire port, put a wire in, and then what?
And then once I close over that wire, and if I have good tug on the wire, I'll lock it, and then I'll put an angio seal on top of it.
Okay, good. I just did 2 of those today. We started doing that about a year ago, and it works great. So I incorporate that in my presentation. My only criticism of that, or shortcoming, maybe not a criticism, is that I really believe it's important to have a completion angiogram. So, it's important for patients. We've had cases where we have thrombosis, low limiting dissection, loss of pulses. And so if you do it in non-ICU setting, then you give that up. But someone like you, if you've done it a lot and you have a lot of experience, you're in the minority. But for people starting programs to try to mitigate complications, we always advocate for taking them back. So, but we'll talk about that. That's a good point.
Okay, we're gonna have a few minutes to have some more people come on here. We have attendees at 14.
So you're not broadcasting. When you choose to broadcast.
How do I do that?
Or maybe it's automatically broadcast.
It is.
Yeah,
Am I broadcasting?
You're on here.
Yeah, I know I'm broadcasting. Great. Okay. Let's look at our list here. Let me go back down. We're going to give it just 5 minutes in order to get our participants. We have 20 participants up right now.
Take your time. I prepared 2 presentations based on our conversation. One is axillary, kind of A to Z, how to do it. And the other one is large bore femoral, some kind of best practices for access and closure. I'm happy to do whatever you guys are interested in hearing.
Okay. No, that's fantastic. That's fantastic.
Oh, I see my friend is there, Robert Wozniak. He's one of my buddies. I really like him.
Where's he at?
He's from Austin. He's one of the good guys.
We're all good guys. Come on.
Yeah. Do you know the guys in Austin? Do you know Robert?
I don't actually, because we're very isolated between the 2 cities, San Antonio and Austin, despite the fact that we're almost merged.
Oh, really?
As far as geographically merged.
Yeah.
But honestly, we work in kind of vacuums between each other. San Antonio, I know most of the people in San Antonio. We're the 7th largest city in the country.
Wow.
Dr. Khaki?
Yes. How are you doing?
Can you hear me? Hey, yeah, Brent New here. I lived in Austin for about 10 years, so I know all those guys.
Oh, do you? How you doing, Brent?
Yeah, good. I'm a CT surgeon
are you?
and in San Antonio now.
Oh, okay. That's awesome. So if you have some constructive criticisms, please share them with us today. It's good to have the input from
Yeah,
surgeons.
no, happy to. I started doing large vessel closures in about 2009, I guess, mainly for aneurysm cases.
Okay. Yeah, I'm going to share some, at least our experience and our best practices that we've done in probably about going on 10, 12 years of large bore with the evolution of mechanical circulatory support, Impella, and now if the guys are interested, I started an ECMO program at my current hospital 11 months ago. We've done 30 cases, about half were VA, the other were VV, and percutaneous cannulation managed by cardiology and percutaneous decannulation. We have a surgeon on backup if we need him, but we've been fortunate this year. We haven't had to use him. He's been very supportive. But I personally,
yeah, that's fantastic.
I think that's the future. ECMO has kind of been always cardiac surgery kind of tool, but I think the future is MCS, in the field, ECMO in the field, ECMO in the ER, in the cath lab. And we're pretty mobile now. We get our cath lab staff know how to prime the pumps, and we're kind of independent of perfusion, but we like having them when they're available. But sometimes it takes them a while to get there.
Yeah, kind of depends on the setup of where one is as to kind of how the team works the best. So absolutely.
Do you do the TAVRs, Dr. New?
Yeah.
Okay.
Yeah, TAVR, aortic stuff. I did vascular for a long time, peripheral vascular, and now it's kind of limited to aortic stuff. But I've been on the TAVR, one of the TAVR teams for about going on 5 years, I guess.
Okay. Great.
And we help some. Our one of the hospitals here in San Antonio now has a very large ECMO program.
Okay.
Went from a small ECMO program 3 years ago to an enormous one in the past couple of years. So,
Okay.
and they're doing a lot of the, percutaneous access for the peripheral ones and closures as well. I
Okay.
had a case recently that I got to see that.
Okay, I'm going to take over the meeting at this point, and we're going to try to get started here. Let's see, I don't see, I got Brent on my screen, but
This is your left.
okay, great. So I
That's
want
all
to.
you need.
Yeah, it's true. That's all I need. You're much handsomer than I am. So I'm very excited to actually introduce Dr. Amir Khaki today, who's going to provide us with this discussion today about large bore access, pitfalls, best practices. And I've been watching his lectures on CAMP PCI and through the SCI website. And I can tell you, I'm very, very impressed with this. And I think we have a lot to learn. As we become a city that's doing more and more large bore access for both mechanical support as well as TAVR, I think this is an important discussion for us to have. And we're very blessed that we actually have some physicians across the system to represent cardiothoracic surgery, Dr. Brent New, vascular surgery, Dr. Nessa Miller, and interventional cardiology, Dr. Chris Pickett, to sit on the panel to have the discussion at the end of the case. And with that being said, Dr. Amir Khaki he's an excellent interventional cardiologist here up in Detroit at Ascension Hospital, and has been really kind of pioneering these techniques in alternative access. And it was that reason that I kind of reached out and asked him if he would do this for us. Just to update you what's going on with the San Antonio Interventional Forum, we have actually on the website officially received our tax ID number now, and we now are a nonprofit. And at this point, we're going to be going out to the corporations with the executive committee and seeking grants to allow us to start to create a grant system. We'll be meeting with our executive committee in the next couple of months to talk about our plan for the whole year, next year. And I'm very excited about that. If any of you have any suggestions or topics that you want to discuss or speakers you want us to look at, I'm happy to email me directly or text me directly. All right, with that being said, I'm going to turn over the meeting to Dr. Khaki. Go ahead, please.
Okay, great. So I'm going to share my screen, and it says host disabled participant share screening. So if you could permit me.
Down here.
Yeah, exactly.
Where am I? Share screen. Okay. We're share. Okay, we got you shared.
No.
Oops. Nope. Let's go back here.
It's just a permissions thing.
Stop share.
Okay, so what am I doing here?
I think you just have to enable others to share the screen, and then right now it's not permitting me.
Yeah, I'm working on it here.
Yeah, take your time.
Oh, that should work, right?
Yeah, that worked.
Okay, there you got it.
Okay. So first of all, thank you for having me, Jamil. So when he called and asked, I told him I would be honored. I love sharing information, discussing cases with my interventional colleagues and the surgeons. The topic I was asked to discuss was large bore axillary access. How do we get the management and closure? And a lot of this work came from Drs. Jamie McCabe at University of Washington, Raj Tayal, who's out in New Jersey, and my partner here, Dr. Ted Schreiber. So I owe them a lot of the credit. I'm going to share with you guys some of our techniques, and I'm open to anyone's experiences or comments and questions. So these are my disclosures. I do speak and proctor for Abiomed and do the same for Abbott. So I think everybody knows this. The prevalence of PAD is in high-risk TAVR patients Initially, when the TAVR, when it was evolving, the sheets were much bigger, and they continued to get better, and we've evolved to smaller sheets with TAVR. But in the early experience, a third of the patients needed an alternative access who had severe aortic stenosis. And the rationale for alternative access then was prohibitive vessel size, small vessels in patients, prohibitive tortuosity, or hostile PAD. And this is, before the era of shockwave and smaller bore sheets. This is something kind of we've all seen in the TAVR workups where very elderly patients, oftentimes octogenarians and nonarians, where have extreme tortuosity, which sometimes can be prohibitive. And we've all have patients who have severe PAD that would prohibit kind of traditional conventional femoral access for TAVR. If you think about partner 1A, this is again, we're going back 10 to 12 years now. A third of the patients needed alternative access. A few years later, we were at 24%, and most recently, we're close to 5%. So the reason I'm presenting this is that although alternative access is becoming less and less common because we've evolved not only with the technology, but we have shockwave, we come up with techniques, expandable sheets, etc. There's always going to be a need for alternative access for some patients. And percutaneous, I think, particularly in the more frail population or when you need it emergently, is a good skill set to have. Which leads me to this slide. The percutaneous options that we have for large bore access are transcable and axillary. And I'm going to make a case that for purposes of interventional cardiology as it relates to shock, high risk PCI, that axillary access is probably a much more practical skill set to have. And why is that? So some of the advantages of transcable is, when you're going transcable percutaneously, you're going from the cava to the aorta, so size is no limitation. You could put 5-liter devices in there. You could do as big as, a big TAVR procedure. You could do ECMO. There's anything that you could do because you totally bypass the iliofemorals. Some of the limitations of transcable, for those of you who have done it or seen it performed, from a technical perspective, it's technically very challenging to do. Ideally, you cannot do this independently by watching a presentation or a video. And there's no dedicated closure device. The risk of bleeding is high. And if you look in the seminal article by Adam Greenbaum, who was at Ford when he kind of developed this technique, their bleeding rates and transfusion were almost 25%. That has gotten much better, but it's still in the double digits. So some of the limitations of transcable are there. If you look at what are some of the advantages of going axillary percutaneously, most Americans' vessels are going to be 6 millimeters. So they're going to be slightly smaller than the common femoral artery. The technique is relatively easy to teach and it's reproducible. The time to insertion is very fast. And I'll show you, we published a paper on this approach in the setting of shock. And our unloading time to access was 12 minutes, and we've gotten even better than that. These patients could potentially ambulate. So I have patients on axillary impella who are ambulating, and that's important, particularly in advanced heart failure population as we start to work with our heart failure colleagues. The bleeding risk, it's very rare that you'll ever encounter a major bleed with this approach, and I'll show you why that is the case. For these reasons, I think this is more advantageous than transcable. What are some of the limitations of axillary? I think they're easy to overcome, but they do exist. So lack of dedicated equipment. The current equipment we have is actually good enough. The lack of familiarity with the anatomy from interventional cardiologists. And by the end of this presentation, you'll know more than enough that you need to know anatomically to do this procedure. The room setup always when you're starting a program is a challenge. Again, with a few cases, we overcome that. And the size of the vessel does not permit us to escalate to bigger devices such as the 5.0 impella. If you wanted to escalate percutaneously, your only option to do that is transcable. And the reason that's important to discuss is some of these patients are actually too sick or time does not permit you to call a surgeon to do a cut down, to get an operating room prepared, anesthesia, etc. So having percutaneous options to escalate care and support very quickly is important. So is this a safe technique? And if you look at comparative data, looking at other alternative accesses, comparing them to femoral, it's interesting. So we're going to use subclavian cut down as a surrogate to axillary. And there's a paper, which I should have put in this presentation, that we published last month, comparing subclavian cut down to percutaneous axillary. And what we showed in that paper, which I'll send to you guys after the presentation, is that it was non-inferior and actually safer as it relates to the bleeding endpoint. And so I think it's fair to use that as a surrogate for the purpose of this conversation. If you look at transapical and direct aortic, and you know, we're fortunate to have a surgeon here, we don't see this much anymore as an access site. And the reason for that is the data speaks for itself. The mortality associated with transapical and direct aortic have made both of those approaches currently prohibitive. So basically now, if you look at these femoral versus subclavian, they're very similar when you look at mortality. When you look at direct aortic and transapical, statistically significant higher mortality, which has led them to go by the wayside. When you compare, these were the current alternative access. This does not include transcarotid, which is proving to be a very good, safe, viable alternative access. At the time of this data acquisition, that was not an access point that we were using for transcatheter valves. Looking at subclavian versus femoral, these were propensity matched, and you could see there was no difference. But as you went to transapical and direct aortic, statistically significant when you looked at survival. So here's the data to support the use of percutaneous axillary. This is the most data that we had prior to us starting an ARMS registry, which has been in the US, which has been submitted for and recently accepted in circulation. So hopefully soon we'll see that. This is the largest experience in Germany with 100 transcatheter aortic valves replacements using percutaneous axillary access. And what you'll notice here is, look in the first 25 cases. The use of a stent graft was 7 out of 25 cases. And then look at the learning curve. At the end, when they got to case 50, their stent grafts were 1 in 25. So they went down to 4% of their cases only requiring a covered stent. And by the way, covered stent is not really, although it's considered a major VARC complication, it's not the end of the world, particularly in these patients that need this access. The patency rate on these stent grafts are actually very good. There is already, 5-year data, but these are large vessels, so I suspect the patency rates over time will be very well. If you look at minor vascular complications, you can see as your experience goes up, it goes down. And what's important to note is what's absent in here in complications. And what's absent here is major bleeding. So you don't see major bleeding as an endpoint because it rarely occurs, particularly if you get access in the way that we're going to describe. So that's important. So this is just showing some histology in the same patient, comparing the femoral artery and the subclavian artery. And the reason I like to show this slide is because I think all of us observe this. And people who have very hostile iliofemoral disease, when you take pictures of their axillary artery, for reasons unknown to us, which we don't understand, oftentimes the axillary artery is spared of atherosclerotic occlusive disease. And that's an interesting observation that we've made, and no one truly knows the reason for that. If you look at them in cross-section, the histology is different, which may suggest some of the reasons why they don't get occlusive atherosclerotic disease in the axillary arteries. This is the ARM registry that was started by Jamie McCabe during my tenure at the DMC. Myself and Dr. Schreiber contributed about a third of these cases. This was presented at TCT and most recently submitted as an abstract. So I'll tell you what we learned from that at the end of the presentation. We're going to move on to the practical part of the presentation on how to do this. And so historically, when you talked about axillary artery cut down, it was always a surgical approach. And oftentimes there's two approaches to the axillary. And this approach, you can make the case that they're actually in the subclavian, but true axillary access historically, when you talk to vascular surgeons, is actually in the axilla. That is actually not done very frequently because of plexus injuries and the high risk of plexopathies with that approach. If you look at the size, we talked about this. This is a nice paper from McCabe and Raj, where they did CT scans on a 100 consecutive patients, and you look at the average axillary artery compared to iliofemoral, it is slightly smaller, but it's the average American has an axillary artery that's 6 millimeters, and that's good because you could put a 14, 15 French sheath in there easily without any issues. So we'll talk about the anatomy, and this is the best way to describe the anatomy to at least an interventional cardiology quorum is just to do the angiography. And we published a lot on this, very basic stuff, step by step, how to do this. But I'm going to walk you through it. And by the end of the presentation, I think you have a foundation to do the case if you needed ever to do one emergently, and electively, obviously, reviewing the presentation or discussing the case would be helpful. So what I like to do is I like to prepare both arms. So if I'm doing this ad hoc, for example, in a shock patient, what I do is angiography of both axillary arteries. And I do this for a couple of reasons. Number one, I like to make sure like to take the vessel that's less tortuous, that's less calcific. I stay away from the left side if the patient has a lima. If you were in a pinch and you had to do that, you could, but keep in mind, if it's a small axillary artery and you put an occlusive sheath in there, you're going to compromise lima flow, and potentially that could be catastrophic. So I would recommend that you avoid limas. If patients have devices such as ICDs and pacemakers in the vein in close proximity, you could do it, but I personally have avoided it. And I've also avoided patients who have AV fistulas on that side, and I use the other side. So those are things to keep in mind. So I do an angiographic assessment of these vessels. This is a cartoon that one of my fellows put up. And what I want to just briefly tell you, there's 3 segments of the axillary artery. The third segment, which you'll see here, which we'll show you in the angiogram, this is the most distal segment. And this is where vascular surgeons historically, when we talk about historical axillary cut down, is where they were getting access. The problem with the third segment and why you want to avoid it, there's a few reasons. Number one, this is where the brachial plexus becomes superficial, and the cords of the brachial plexus are superficial. If you go to the second segment here, the anterior surface of the axillary artery is devoid of plexus cords. So this is the ideal spot that you want to stick the second segment. As you start to see the first rib come in here, this is where you're in the chest. And if you have a bleed here, your only bailout is going to be percutaneously with the covered stent. The problem with invading the chest is not only bleeding into the chest if you have that complication, but also having a pneumothorax. So you never want to get into the chest. And if you talk to the surgeons, and we'll get their opinion, this is a very difficult spot for the surgeons to get to quickly. So if you stick in the second segment, which is A2, this is what I like to call the sweet spot, which I'll show you on the angiogram. The reason it's important, there's several reasons. Number one, this is actually compressible, and I'll show you that in an angiogram. The other reason it's important, you're away from the brachial plexus. And another reason that it's important is in your early experience, you're going to end up using covered stents. And if you use a covered stent here, there's no big deal. However, if you cover this, you could have, if you're too distal and use a covered stent, this is a meaningful vessel. It provides flow to the humerus, and the potential complication is avascular necrosis of the humerus, which you don't want. So you don't want to be too proximal for the reasons we talked about. You don't want to be too distal. You want to stick in segment 2. So how do you do that? The easiest way to do that is angiographically guided. So if you look at this, here's your ribs, okay? And so this is going to be A3, A2, excuse me, A1 proximal, A2, and A3. So here's your runway. So you have, a good, 20 millimeters of vessel that you could, 20 centimeters of vessel here that you could stick. The raccoacromial artery, clinically not meaningful. The subscapular artery is usually a big vessel that you see that runs south. What runs north in the same plane is the circumflex humeral. So this is going to be your distal border, and the chest is going to be your proximal border. You want to stick right in the middle. Okay, so we'll show you how to do that. And here's the better picture. Again, here's the chest. You never want to enter the chest with the needle. You have a great long runway here in A2. And here's where you have meaningful vessels that you don't want to cover in case of a bailout situation. And furthermore, here's where you have cords of the brachial plexus, and you can cause plexopathy. So for these reasons, it's very important that you stick in this spot. So really good closure is going to start with really good access. A couple other things, the nuances that I've learned over the years is the angle of entry of the micropuncture should be in the same plane. So what I'll do is I'll do a roadmap on these patients, and I get angiographically guided access. I don't use the ultrasound. And what I'll do is I'll draw a mark with a marker. I'll draw a line, and I enter the vessel in the same plane at a very shallow angle. And wherever I want to stick, I'll precisely stick there. So here's a case that we did live for TCT. And you could see, basically, here's my micropuncture. I'm doing angiographically guided access. I have a catheter in the subclavian artery. If the patient has renal insufficiency, you could take a wire, use that wire and stick it as a target. I often will mag this up and do a roadmap. If the patient is sedated and not moving, it's a great approach. Once I get in there with the micropuncture, I'll do an angiogram to make sure that I'm in ideal position. And you can see it's in a perfect spot. Here's a case that we did live for TCT a few years ago. A few things I just want you to see is I used a J wire here as my target. There's my micropuncture.
Yeah, it's Lopez, right?
And then I'll put the micro wire through here and take out the micropuncture. And you got to keep in mind, you are going through pec minor, you're going through muscle, but most of these guys are and gals that you're operating on are not bodybuilders. It's a lot of atrophic muscle there. And so why is that important? Because it does not take a lot of force, and you'll see this in the next slide, to go through the muscle. So you shouldn't be pushing very hard to get these sheaths in. After I have the small bore access, I do the pre-closed sutures. What I will tell you also, what evolved with our experience, is that the vessel is very friable and delicate. So you can't, sometimes I see, myself included, we're a little heavy-handed with the femoral artery. It's much different in the axillary artery. If you're pulling really tight with high tension, the foot plates could come through the vessel. We've had perforations and renting the vessel. So when you're doing axillary access, just have to respect the vessel more than we often do in the femoral. Some other important nuances are always deliver large bore sheets over stiff wires. The 3 stiff wires that I would recommend, either one would work, is an Amplat super stiff, a Lunderquist, or a super core wire. My preference is to put my per closes in over the super core wire, and then I change out for the Lunderquist to deliver the large bore sheets. And we do that for TAVRs and Impellas, and it makes a really big difference. You should never do this over a standard J wire. And here's what I wanted to show you. So here I have a Lunderquist in. If you look at my hand, it's very little energy and force that it takes to get through. And I also hub my sheath. This is a short Oscor sheath, and I'll hub it. And the reason I hub it is it's stable. There is vessels, the cerebral vascular vessels here. There are some concern in patients that you could have a stroke by leaving it in there. I've never had a stroke, and I've left the axillary in 14 days is my longest patient. But just keep in mind, these patients are always anticoagulated, and we pay very close attention to the ACT. The vessels are very tortuous sometimes, particularly in older patients when we're doing TAVR or shock patients. And you can see we have the wire in there, and you could negotiate. This is just showing you just gotta have your buddy or assistant pulling tension on the wire, and oftentimes you could overcome the tortuosity. This is what we do in shock patients when we have to leave the Impella in. We leave the sutures in there in the axillary position. I'll put the swan through the neck, and the reason we do that is the patient could sit up in the ICU, which is an advantage, particularly when we talk to our heart failure colleagues, and you could ambulate these patients. So the question always arises is, what about the per closes when you bring them back? Are there risk for an infection? Cindy Grimes was here. We published our experience of over 100 patients with delayed closure, no prophylactic antibiotics, and we did not have any infections. All we did is per IFU was betadine the areas. This is really important. Before you do any axillary artery, the first thing that you should do, access, whether you're doing this for TAVR, for Impella, or for ECMO, the first thing I always do is get ipsilateral radial artery. And I learned that the hard way. Having ipsilateral radial artery on the site that you're going to get your axillary access is critically important for a lot of reasons. Number one, if you have any complications and you can't bail out from femoral, you could control the vessel. You could deploy covered stents. You could manage occlusive sheets. And we'll talk about all those complications. But the first thing you should ever do when you're even if you're doing it for TAVR and you know it's coming out, I highly recommend having ipsilateral access in the radial artery. We published a lot on this, and I'm happy to share that with people. If you look at our early experience, and I'm going to share this with you for historical relevance, but you don't have to do this anymore. As we were evolving and learning how to do this,
okay, here's the Impella sheet.
We would take a picture of the Impella to make sure it was not inclusive. This is in a shock patient. And if it was occlusive, you didn't want the arm to fall off or have acute limb ischemia, so you had to get flow down there. Before we knew better, we would get antegrade brachial access post hoc after we found out that this was occlusive. Now, there's other things we could do now. This is a peel away sheath. You could peel away the sheath. If you had a radial access, then you hook up to the radial. But I'll just show you what we did in the early experience, which was very hard.
Sheath, what we're going to do is we have a male-to-male connector. We're going to open this, okay? And now we're going to open here, and you're going to see, and that's how you have an axial brachial bypass external.
So that's something that you don't need to do anymore, and I'll show you why. This is another patient when I was at a small hospital putting in an Impella. She was occlusive. She was a horrible vasculopath, this young lady, and I could not get flow down the arm. And so what I did is took femoral access, which I did the PCI, and I put a glide catheter from the femoral access. I ran it along the Impella and basically did a bypass. So blood would come out of the femoral sheath back into this glide catheter. This glide catheter was distal to where the Impella is. The proof is in the pudding. When you do this stuff, you got to make sure you got flow to the hand. And when we do an angiogram, you can see that we have adequate flow to the hand. This patient actually survived and needed the Impella in for 3 days, never had any issues with the hand. And what I've learned, I'm doing a lot of these cases, is that the extremities, both the arm and the leg, don't need a lot of flow. So when the nurse calls you and says, you know, the blood pressure is down in the left arm where you have the occlusive sheath, as long as the patient's getting a little bit of flow and it's not totally occlusive, they actually do pretty well. This is why I think it's important to have radial access in all these patients. You know, one of the reasons. So in all the patients now, I get radial access. If I'm occlusive at the end of the procedure, I just do the same thing, but I hook up to the radial. This is much easier to do preemptively than it is ad hoc, and I'll show you this. Sorry. So let me just see this, if it's gonna play.
Large bore, the side arm, and then the main connector will start the flow here, forward, and then by opening the radial axis, the flow comes from the large bore side arm to the radial, and you have perfusion distal.
Yeah, so large bore occlusive sheath management is important, particularly in MCS patients with shock when we're keeping these large devices in people. This is going to be really important as we're doing more and more ECMO cases. My advice to everyone who's doing percutaneous ECMO is, you know, most of the cannulas that you're going to need to get the flows that you want are going to be on the arterial side between 15 and 19 French. And most Americans can't tolerate that without being occlusive. So on all my ECMO cases, I get antegrade access preemptively before I put the ECMO cannulas in. And even if the patient is crashing, trust me, it pays dividends to get that antegrade sheath in, you know, a priori, as opposed to post hoc becomes challenging. So we publish this. So how do you get this, if you're doing these cases, how do you get these large bore sheaths out of the axillary artery safely? So in this particular case, it's an Impella device, but the same thing would apply for a TAVR or an ECMO if you're doing an axillary. And rather than go through the didactics, I could just show you. It's much easier. So what do we do on all these? In your early experience, my recommendation would be to use the femoral artery as the artery that you're going to use for closure. And I would use a 7 French. And the reason you're going to use a 7 French is it gives you a lot of options if you don't get successful hemostasis for bailout. What I do is I put a 7x90 sheath, which a lot of us, for those of you who do carotid intervention, they're on the shelf. If you're not familiar with doing endovascular procedures, then I would call your colleague who does peripherals or your friendly vascular surgeon who does endovascular work and ask them to assist you. If you're a dedicated coronary operator and don't have advanced endovascular skills, it's best to have somebody with you when you're doing this. And this is very teachable. So you'll just need a few cases because you get familiar with the equipment. But what we have here is a 7 French carotid sheath. And then I have a balloon in the proximal subclavian artery. And I'm basically dry closing the percloses. So the next thing I do is after the balloon is blown up in the proximal coronary artery, in the subclavian artery, I take my percloses down. These patients, if you have pre-close, and I'll show you what you could do if you didn't have time to put the pre-closes in. So what this does is you control the vessel and basically you're tying the sutures down in a dry field, assuming that the patient had pre-close. How high do you get to go on this balloon here? This is important, and I'll tell you why it's important. In this particular case, you have a large bore sheath here, which you don't see in the screen. You should have a pressure transducer hooked up to that large bore sheath. and you have a pressure transducer hooked up to the femoral artery, and they should be overlapping. And when they're overlapping, what you do is you take this balloon and you blow the balloon up until you see the pressure transduce. The transduced pressure start to dampen, and oftentimes it'll only take 1 to 2 atmospheres of pressure. So you're not trying to blow, do angioplasty or damage the artery or blow up a plaque. All you're trying to do is diminish flow. And the best way to know how to do that is just do it under pressure transducer guidance. You deploy the percloses, and then then you do your final angiogram. This is an important paper that we published. If anybody has any concerns about leaving percloses in the femoral artery in the shock patients or in the axillary artery for fear of infection, this data should mitigate that. We've been talking about this for 7 or 8 years, and there's been only one case that's been reported with infections secondary to delayed perclosure, and there's been thousands of cases done. Once you do your deploy your perclose after the balloon tamponade assist, you take a final angiogram. Always take it under subtraction and make sure that you have hemostasis. If you make sure that you don't have any flow limiting dissection. Oftentimes you'll see a dissection flack, but it's not flow limiting, and make sure you don't have thrombus. Those are the 3 main things that you're looking for. In this particular case, you can see that we do not have adequate hemostasis. You can see there's a puff of contrast coming here. And so what do? That same balloon that was in the subclavian that was helping with the dry closure, I advanced it to the arteriotomy site. And what's important here is you can see where our puncture was. Our puncture was right in the second segment. You can see we were far away from the chest, and we were far away from the circumflex humeral and the subscapular. So the next thing you do is you blow your balloon up there, and you leave it up there for 5 minutes. And how do you know how high to blow the balloon up now? Because you don't have the transducer. So now you blow the balloon up to direct visualization. So you're looking at the arteriotomy site in the skin. As you blow up to 1 atmosphere, 2 atmospheres, you keep blowing up until you see no more blood coming out of the skin. You leave it up there. If you're patient, you should do it for 10 minutes. If you're like most cardiologists, 10 minutes is really 5 minutes, and then you take a look. So you do an angiogram, and this is a case I wanted to share with you where I had a fellow, we were transmitting this. This was a live case I was doing, and we blew up. I told the fellow to go to 2 atmospheres, and we went to 20 atmospheres. So this is the worst complication I've seen as it relates to perforation. And what's important about these slides, I'm going to show you a few things. Number one, if you didn't believe that manual pressure works in axillary artery, here's an angiogram with me holding manual pressure and a perf that's this big. And you could see that it's manual pressure does work, okay? This is us taking the Viabond down there. This is a self-expanding Viabond, but what's really important is, again, we had access in the second segment, which was very precise. And my goal here is to cover this big hole without compromising the circumflex humeral. Now, if I would have been proximal in the chest, this patient would have bled into the chest, and it would have been a problem. So here we deploy the Viabond, and here's my final result. And what you see in the final result is preservation of the meaningful branches, no more extravasation of contrast. And so it works. So that's why when you're doing these types of access points, it's really critical. Your closure is going to depend on your access. And so spend a little bit of time, be very meticulous. If you get a good access and you have an unfortuitous complication, you're likely going to be able to bail out if you started the case right. So what do? We don't do this step anymore. I used to be concerned about a thromboembolic phenomenon to the hand, and I quit doing this because we don't see this. So you don't have to do that anymore. So in summary, axillary artery allows patients to sit up. You could walk short distances, particularly in patients with advanced heart failure, ischemics and non-ischemic decompensated heart failure who are getting bridged to recovery of native heart or bridged to definitive therapy with VADs or transplants. I think it's the best alternative access as it relates to ease of use, early insertion time for unloading, and patients do a time-sensitive diagnosis. Obviously, it's a cleaner site, and the patients aren't laying flat. Technically, it's the least challenging one. We did publish our experience, and someone once asked me, so this was 17 patients. Of the 17 patients, the mortality was 67%. And so 30% survival in patients who had axillary for MCS and cardiogenic shock, in my experience, in the first 17 cases, which seemed like an extremely high mortality, and it is. But I would submit to you it would have probably been a 0% survival. if we did not have this alternative access. So if you're getting an axillary impella in the setting of shock, then you're probably very sick. These people are vasculopath and shock. So this is something I give this lecture often to young fellows, my fellows, and other fellows in our region. And I tell them that it's a call to action, that if you want to be a good, competent interventional cardiologist in contemporary times, you really have to be equipped to be able to deploy alternative access, particularly if you're taking STEMI call or you're on a shock team, because having these skills, I think, could potentially save your patient's life. Here's kind of the toolbox when people ask, what do we need to do axillary? And if you look at all these different tools that we have, these are common tools that everyone has in their cath lab. And if anybody wants this presentation, I'll share it with Jamil, and I'm happy for you guys to use it, for education or whatever you need it for. So this is how I like to end this presentation, because I think we need to demystify a lot of things that we do in interventional cardiology so that our colleagues could learn how to do them and potentially other patients could benefit. And I've had the honor to go proctor people all over the country and in Europe and the Middle East. And the most interesting one, and I talk about this one all the time, is I was in this area. I'm right now currently in my home library. In the same library, I was called one night and by Dr. KM, who's an interventional cardiologist in St. Louis, who had a patient who presented in cardiogenic shock, and he had seen one of my talks and got a hold of me from another person who knew me, and he called me in the middle of the night. He had a patient who had severe aortic stenosis, and he needed to balloon her aortic valve and treat her left main. She needed mechanical support. He'd never done this, and what we did is we FaceTimed each other, and you could see me here in FaceTime, his nurse is holding it up. You could see the axillary artery, and I walked him through it, and he did a great job, and his patient got the access and survived. And the reason I like to talk about that case is that this is a procedure that can be done. It's easily reproducible and teachable, and I think we should be helping each other do these complicated cases so that more and more patients can benefit. So thank you for your time. If you have any questions, I'll try my best to answer them. And if time permits and you want anything on the femoral side, we could do it. But if you have cases, that might be a better use of your time. So thank you, guys.
Well, that was simply fantastic. And can people hear me?
Yes.
Okay, great. That was simply fantastic. I really appreciate your time and that excellent talk, Amir. And, as the president of the SAFE group, I get to ask the first question. Do you dry close your femoral access also?
Yeah, so that's something that we've been adamant about for about over a decade now. We strongly believe, at least the group here in Detroit, that all large bore access sheaths should be taken out in the cath lab using the same technique. We have started adopting another strategy, which Jamil, which I think you've been doing much longer than us, but we have been closing over the wire on some of the patients and foregoing the balloon tamponade if the patient had extreme tortuosity. We're having a hard time getting up and over. We would close over a wire, and if we don't have good hemostasis, we would tack on an 8 French angioseal. We've had tremendous success with that as well. The common thing that we do all the time is we do get final completion angiography on all these patients before they leave the cath lab. And the reason I think that's advantageous, there's some cases I could show you, even TAVR cases, where the final completion angiogram, there's no oozing, there's no bleeding at the site. And, we're all, patting each other on the back on another great case. We do the final completion angiogram and the patient has a undetected bleed. And now that we detect it, we could treat it with balloon tamponade. We have good surgeons that can do a small cut down. And these bleeds are not recognized later on when the patient has a drop in hemoglobin or an expanding hematoma in the ICU. So I think there's tremendous value to completion angiography, and that's another reason why I believe that it's safer to bring patients back to the cath lab.
That's wonderful information, very good advice for us. Our next case, we have 3 cases to present to you tonight. Okay. The first case is coming from Heenan Ahmet. And Heenan's a good friend of mine over at the University Health Science Center of San Antonio, interventional cardiologist there who has taught many, many, many fellows. And he'll be presenting our first case. And I just want to make sure we got him here. He is unmuted. I'm asking him to
Yeah,
unmute.
I can hear you, Jamil. Can you guys
Right.
hear me?
Yes.
Yeah, you gotta let me share the screen. Here you go. And let's do this. All right,
There
can
we
you
go.
guys see my
We
screen?
got you, Gannon.
Yes, Dr. Khaki, thank you very much. Great, really great presentation. I appreciate you having time and spending some time with us.
Heenan, you're echoing.
My case is honestly a pretty straightforward case, but before I start, you can hear echo on my voice?
I do. Do you have two speakers on?
It's a connection issue.
Not really, no. Let me see. I'm gonna try to get closer to this and not speak too loud. Is it better?
Better.
Yep. Okay. Some of the questions and answers
No, that's worse, actually.
that were, I had written down some questions, but I think you answered. Now?
Go ahead.
So the case I'm presenting is aortic stenosis TAVR. And this is this is a case from a few years ago. And we used to get a pigtail up and over, shoot an angiogram, as you showed, do an angio-directed access. So my question was, and you answered it, I think you do a roadmap guided access as well versus an ultrasound guided access, but I wanted to ask you for femorals if you do it as well. And we used to leave a wire through an 014 or an 018, but we've stopped that practice. That was to do a dry closure at the end of the case. But I want to hear your thoughts on the femoral if you, and I think you answered that. You said pretty well. So I'm going to go right to the groin problem. And immediately at the end of the case, as you mentioned, we do a completion angiogram, and this is what we see. Jamil, can you see my screen?
Yes, I can see your screen.
Yeah.
Can you see, Jamil, can you see it? Okay.
Yes, sir.
So yeah, immediately we noticed pulse, distal pulse was gone, and this was the picture we have. Fortunately, it's a nation chief, and I agree with you, Dr. Khaki, a 7 French basically gives you a lot of options. So we went up with a destination 7 French support catheter and a glide wire, and we're get access across this occlusion. Did a distal injection to confirm we were in the true lumen. This is for funda, and with easy get the wire down into the SFA. We did slow, gradual balloon inflations. I started with a small caliber balloon and then gradually extended to the 4 millimeter balloon. What we got, in spite of prolonged balloon angioplasty, or recall on this vessel was pretty severe. So to really do this, I had no option to deploy it, and this is our final result. Jamil?
Eden, your audio is really poor at this point.
Questions I had, I have a second short case that I'm gonna actually through this, and at the end of the case, okay. Well, then I'll let you take more.
Yeah, go ahead. Try to tell us your second case.
Wait, I just want to
I was gonna say, if you have a perforation case like you showed, and you do a prolonged balloon tamponade, what's your heparin strategy at that point? Obviously, you don't want to give too much heparin because the perforation will kind of make it worse, but at the same time, you're performing a prolonged balloon angioplasty.
Okay, I'm going to actually repeat that for Doc.
Thrombosis can be a concern.
I'll repeat that for
How
Dr.
do you
Khaki.
handle your heparin at that?
So Dr. Abed wants to know what your balloon inflation time is. He wants to know what your anticoagulation strategy, both acutely and long-term, is for those patients who have perforation.
Okay. So one thing, I always want to make a few comments on his first case. And I think, you know, I don't know what the strategy is in Texas. At our hospital, we're a little bit behind the curve as it relates to, you know, the sedation strategy. So we're still on our TAVR patients. We're doing a lot of general anesthesia with TE. I know a lot of people are moving to more minimally invasive, you know, not intubating and using transthoracic. But the problem with, you know, with some of these cases is my patients are intubated. So had he not taken that final angiogram on that patient, the acute limited ischemia would have been recognized later. And so he should be commended for the angiogram. And that's the advantage of having the final angiogram. He recognized that complication. He was able to deal with it in a timely fashion. So you know, that I think that brings home the point about why it's so important to do completion angiography. Regarding that particular complication, the thrombosis, if it was an Impella patient, then, you know, if you're bleeding regarding the perforation, if you're bleeding and it's an Impella patient, they likely had a PCI and the Impella is going to stay in probably because of shock or whatever the reason is. If they had a recent PCI, I'm very hesitant to give protamine. In TAVR patients, if I have a leak and I'm trying to avoid a cut down or a covered stent, we routinely give protamine. So it really depends on the clinical situation and how bad the perf is. You'd be surprised, a lot of these extravasations of contrast with balloon tamponade and simultaneous manual pressure in the cath lab, after 20 or 30 minutes, you do an angiogram and they seal. So I don't think you should have a low threshold to use covered stents in these patients unless it's very obvious when the patient has a rent. Particularly, you know, people think, you know, well, a lot of the thinking is that the patient's 90 years old, they're getting a TAVR, it's a small price to pay. I think that we should avoid covered stents at all costs. And if there's no other option, then it's not a bad bailout as opposed to having a surgeon cut down on them. But I could tell you a few weeks ago, I had a patient, we did a final angiogram. He was a young guy, prohibitive risk for TAVR, not really prohibitive, but he was high risk for surgery. The surgeon didn't want to operate him because he was morbidly obese. He was really fat. And when we did our final angiogram, the access site looked beautiful, but we saw that there was a lot of extravasation of contrast. We did balloon tamponade for an hour. It didn't go away. Now, this guy was 70 and he was you know, although he was fat, he liked to golf and do all kinds of stuff. So we spared him a covered stent because the surgeon was there. He said, look, I could cut down. He repaired it. Patient still went home the next day. If that same patient was a 90-year-old, we probably would have put a covered stent. So having the 7 French up and over does give you a lot of options. And if you have a really good surgeon who's your friend, you could try to make these decisions that'll best serve the patient over a longer time. So that's been my experience.
Great. Well, we're going to move on to our second case. Excellent comments. Thank you, Ahmed, for giving that case for us. The next case is actually going to be by Devang Patel, another good friend of mine from the cardiology clinics of San Antonio. So I'm going to turn it over to Devang. Go ahead, please.
Thanks, Jamil. Thanks, Dr. Khaki, for your presentation. It was very good. I actually have another TAVR case with a pretty decent TAVR program. So I'm going to share my screen with you. I don't know if you can.
Yeah, if you guys don't mind, just call. You could address me as Amir. You guys are too formal in Texas.
Okay. Amir, so here's my slide. Let me get slideshow started. Here we go. All right, so this was a TAVR. This was the pre-TAVR slide deck that we get from the CTs from the radiology department. So the measurements in the iliofemoral side were about 7 to 8 millimeters. We felt confident this was going to be a reasonable TAVR case. This is the stretch and CT angiogram. There was some plaque and calcification, but really nothing that would preclude us from going the femoral route. I don't know whether you can see, but there's a small sort of dissection, linear dissection on the right side from a prior diagnostic catheter intervention. So we should be on the left side for our large bore sheath and 6 French on the right side. And this was the vessel anatomy, really a little bit of tortuosity, but again, not too prohibitive. The bifurcation on the left was just a little bit high, but not too high to be prohibitive. So we try to stick just above the bifurcation there.
Yeah.
This was our pre-angiogram, so we landed above the bifurcation. Really, the case itself went fine. It was an Edwards sheath. It was a 26 valves. It was a 14 French sheath. This was my angiogram post. So completion angiogram on the right side. What you see here is this haziness, which I initially thought was thrombus, and there was sluggish flow beyond this. And I thought, let me see if I can go across and over and open this up. So so you can see this is a still image. You can see this linear density up here. And I thought maybe from the sheet it was occlusive, and we had a tail of a thrombus. Went across and over, managed to get through, balloon down, back and forth. Really couldn't get good flow. And then I thought maybe it wasn't a thrombus, maybe it was a dissection flat.
Yeah, it looks like a flow limiting dissection there.
Yeah, so I called, actually Dr. Miller's on this call. I called Dr. Miller over, and the patient actually was extubated, went to holding. She looked at the patient, went back to the OR. And this was her findings, a large dissection of SFA that extended down the CFA and portion of the SFA. And then she did a nice job of revascularizing the leg. And then patient recovered, went home. But, you know, I've changed my technique. Just, you know, for my TAVR patients, I don't use 2 percloses. After that group in New Jersey published the angiosil data, I just do single perclose and then I seal with an angiosil, and I've had less ischemic complications with that. But and I want your thoughts about what you would have done differently, or how you could prevent these kind of, you know, tears in the vessels. Obviously, it's an elderly patient that's very friable arteries.
Well, first of all, I want to commend you. You know, you did the final angiogram, which we keep trying to drive home, and you recognized the complication, and it was dealt with appropriately. So you and Dr. Miller should be commended. I thought it was a dissection right when I saw it. And what usually works when you recognize a dissection is I would have done exactly what you would have done. I would have done a prolonged inflation. You do have the advantage of the size because you had the advanced imaging with the CT. And I think I would have taken, I don't know what you did. I would have probably taken a 6 or a 7.0 long balloon, 7.0 by 80 maybe, did a prolonged inflation. And to be honest with you, having a dissection there is not an issue so long as it's not flow limiting. In your particular case, it was. You saw that you said the patient was symptomatic and you lost pulses, but usually those are pretty benign if you do a prolonged inflation and establish flow, that, you know, and they'll heal on their own.
I will say that because I saw the inside, which is something that surgeons have the advantage of, right? Like
Correct.
I see the inside of the artery. It can be challenging in these patients with atherosclerotic disease, and, you know, it's a long case already, and now you've gone up and over. It's challenging to get your wire into the true lumen. It really can be with these large dissections. And I think Dr. Patel did a lovely job of saying, you know what, I tried this, I gave this a college try, and I have now reached the limit of what I think is appropriate. I don't think it's wrong to say what you're saying at all. You know, a non-flow limiting dissection, easily you can tack it down. I think that happens, that works great. But if you're not making progress and it's not going well, a surgeon would much rather know about this sooner than later and not at 2 a.m. And from a technical standpoint of doing complicated endovascular procedures, it can be hard to be in the right dissection plane. God forbid there's multiples.
Yeah. No, I agree. Your point is well taken. I think if he could get a hydrophilic wiring in the distal lumen, the true lumen, and blow a balloon up, most of the time this will resolve. In the absence of doing that, particularly in this case where it's flow limiting, having a good surgeon with you, and I'm not a surgeon, but my understanding from the surgeons, this is a relatively, the durability of what you did is long-term, and you guys are really good at cutting down and repairing these arteries, and it's not a lot of associated with a lot of morbidity, as a lot of cardiologists often think of surgery. So I think what you guys did was awesome. The collaboration, the final angiogram was great. Congratulations.
Hey, Brent or Chris, do you have any comments, please?
I'll go ahead. I think that you guys have hit on a very valid point that I think we're lucky at BAMC that what we've had with our kind of TAVR team and our large bore team is we can't, as interventional cardiologists, and I think Dr. Miller may appreciate this, or perhaps not, Dr. New perhaps, is we are closely entwined with everything that we do with our cardiothoracic surgeons and our vascular surgeons. So I think the great working relationship that we have between our two groups allow us to, when we have these sort of complications, to quickly and appropriately assess what is going to work for our patients. And so I guess it's the heart team, the ACC pushes it really hard. And I think this case nicely illustrates just the value of having the heart team. It's not just the cardiologist and the patient, it's the whole spectrum of everyone.
Dr. New, any comments?
I would say, Jamil, a couple things. As he said before, your closure kind of depends on your access. So having good access and having it directed from a femoral standpoint, I think we do a lot of more blind or fluoro-guided access for large, vessel closure, and I think, underutilize some of the other techniques, particularly with ultrasound guidance or with road mapping, to really get a good center punch in some of these cases where the femoral vessel may not be ideal. And then also the completion angiogram, I fully agree. It takes a little bit more time and effort, but it's something worth doing. And sometimes you find the surprise that you'd rather find out about there, have a good discussion about, and decide how to treat it. Whether it's with a cut down, on the spot, or with a transcatheter technique. But I think that can't be overstated.
Absolutely. Dr. Alamani had a question. Go ahead.
Yeah, well, I want to say, we do what everybody does, almost everybody does. We get, for TAVRs, we get the large bore on one side, and we get the other arterial axis on the other side, and at the end we do a completion angiogram. But recently I've been entertaining an idea of something that I've heard that people are doing, getting the small second axis just like 3 or 4 centimeters below the TAVR axis. And it's like a 6 French or 5 French maybe in the SFA, and just use it for the pigtail port, and at the end leave a wire in there and do your completion angiogram from the same side. You're in the lumen, you have easy access to the large arteriotomy site. I've not done it, I've not tried, but I just want to throw it there, see if anybody tried it or has a comment on if that's worth it technique worth it to switch to.
Thank you. Any comments, please?
I haven't really observed that and seen it. I'd be concerned with some, crowding, particularly with the large bore sheath and that femoral artery, and then you're probably going to end up putting that sheath that you're talking about in the SFA. So I would be a little bit concerned. I think, fundamentally what we're doing, with large bore access, particularly when we talk about the best practices, the fundamentals of road mapping, ultrasound, completion angiography, dry closure, balloon tamponade. I think if you do that routinely, you could expect low single-digit vascular access complications. And I think it's just a matter of us being disciplined enough to do these things all the time, every time. So I think we have a really good algorithm now, just getting people to adhere to it and to believe in it. And I think we could get 1 to 2% large bore vascular access complication. We should be expecting that.
What a fantastic goal. Our last case is Dr. Chad Christophs, another great friend of mine from River City Cardiology in San Antonio. And Chad has an axillary case he wants to present for us.
Okay, cool.
Okay. How do I do this here? Can you hear me?
You need to enable your web because none of us can see you or your slides.
Well, enable my web. How do I do that? I'm sorry.
All you have to do, if he permits you to share screen, there's a green share screen arrow. If you click on that, if you're permitted to.
Yeah, it should be down in the center of your, the bottom of the center.
Share screen. Got it.
Perfect.
Okay. Desktop one, what does it say?
Click on the one that you want.
Here.
And Dr. Amir Khaki is not only an interventional cardiologist, but he's the IT specialist for tonight.
There you go. Gosh.
I have to be honest with you. I barely know how to type, and I've learned how to do Zoom. That's about it.
Well, my youngest, the 20-year-old IT computer science major, is not here tonight to help us.
I am really sorry. Thought I'm doing everything I'm supposed to here.
Did you select the video over on the bottom left side where you're sharing video?
He's a panelist.
It says start video.
Oh, there we go. We got you.
Oh, okay.
Yeah. Video's
Good.
up. I have your first slide,
Well,
but we don't have video from you, but that's okay.
That's all right. We don't need to be seen. If you can at least get the slides up, that'd be great.
Yeah, we know you're a Viking fan. You don't need to be seen.
Yeah. Well, hey, I got the Packers are playing the 49ers, and dear God, I have to hope the 49ers win. Jeez. Okay. Oh, it's frozen.
Okay, for some reason, I'm going to ask you to start sharing video.
Okay, start my video.
There you go. We got your screen.
Okay.
Close that out. Don't deny me.
I'm not going to deny you.
yeah.
It just keeps trying to tell me to open system preferences, and I don't
Yeah,
want
just
to
get rid
do
of
that. Yeah,
Yeah, we see your
God,
desktop.
I feel like a retard. All right.
Just pull up the PowerPoint that you need.
Perfect.
Open
Yeah.
the PowerPoint.
Mm-hmm.
Okay, I'm doing.
We can all see it.
Yeah.
Okay.
And there you
All
go.
right.
Put it
You
in.
see it?
Chad, we got you.
Okay.
Now just put it in presentation mode. You got one more click. There you go.
There we go. Okay. So an axillary impella. I was fortunate enough a few years ago to have about 30 to 60 minutes to sit down with Dr. McCabe to discuss doing axillary access. And so just basically to show kind of a case, this is a 60-year-old Hispanic male who presented to one of my partners in the emergency room. He was in he was in shock. Blood pressure was 80. He was tachycardic to 120. They did an echo in the emergency room, and he had a dilated cardiomyopathy with an EF of about 20%. There was no fever. There was no other absolute reason that we thought he might have a shock other than a cardiac source. The lactate was 6 in the emergency room. So I was in the cath lab. He called, and we brought him up to the cath lab for emergent coronary angiogram and right heart catheterization. We'll show the pictures, but the coronary angiogram revealed non-obstructive coronary disease. The first thing we did was put up a pigtail. His EDP was 30 on the left heart cath, and we decided that we wanted to proceed with ventricular support. I guess my favor is if I have a patient who I feel is going to be less than 48 hours, I use femoral access. But if it's going to be more than 48 hours, I usually try go axillary because in my experience, the femorals after about 2 to 3 days always seem to bleed. And so I got femoral access to take some pictures, but the plan was to proceed with ventricular support. So the first thing after the EDP, we took a picture of the subclavian, and obviously has a wide open, nice subclavian. Sorry, I did a crappy job of getting, but this is the right coronary artery, no obstructive CAD. The left, again, no obstructive CAD, so it was a non-ischemic dilated cardiomyopathy. On the echo, again, the EF was about 20%. His blood pressure was running in the 70s to 80s on Levophed infusion. So we put the axillary impella in through the technique that Dr. Khaki was speaking about. We got access with a Lundquist wire 7.0 balloon for occlusion. I'll show some pictures here in a bit. Over about the next week, the patient recovered. The nice thing about the axillary is we're able to get him up in the ICU and even walk around, and he actually did very well. Approximately about a week after the initial event, it was felt that he was stable enough to remove the impella, and so he was brought back to the cath lab. We got femoral access, and I apologize because I realized that I did a poor job of documenting than I thought. Because actually in the middle of this case, the patient had a respiratory arrest, and we ended up having to do CPR on the cath table. So the angiogram here basically shows there's a balloon occlusion there, and it's hard to appreciate. I had pre-closed him, and so this was after the pre-closed sutures were deployed. There was this stenosis, which I maybe would have considered either leaving alone or doing a lone balloon inflation, but he continued to have severe bleeding and extravasation out of the access despite manual compression. And so we were trying to figure out where do we go. We occluded the subclavian with a balloon to give us time. One of my favorite things to hear from our cath lab people is the doctor, we don't have that. And what they came back with is that our Viabonds weren't, they didn't have any 8mm Viabonds. All they had were up to 5 to 6. I have corrected that, but that was what we had at the time. So Dr. Miller unfortunately was not around or available at this time. We were trying to determine what to do. So we actually got, and as Dr. Khaki said, I really wish at that point in time I had radial access. I did not, but I was able to get brachial access and came retrograde and put in a covered stent. Again, this doesn't look wonderful. I did post-dilate this. Again, like I said, I am unhappy with myself as far as my documentation on this, but we actually did have a nice result afterwards. We had no further extravasation, and we had normal blood pressure in the arm. So, Brian asked me to give this because he was there at the time. He was actually the cath lab manager, and he was kind of running around. We were trying to accomplish this, and again, trying to pull it out of several orifices at the time. But anyway, so the patient recovered, actually went home in a few days, actually did very well despite his respiratory arrest on the cath table. His ejection fraction had improved from about 20% to about 35%. We figured he probably was in a viral cardiomyopathy as the etiology. And like I said, I wish I'd have documented some pictures better, but like I said, we did the balloon occlusion, which was very fortunate. And does anybody have any questions?
I just have a few comments. One is, that's awesome that you were able to do the case, and I think that speaks to the fact that, that it's teachable and reproducible. It's interesting. It's interesting that you were having, it looked like to me that you had thrombosis in the setting.
Yes, there was some clot there as well. I agree.
And I'll tell you this is kind of the dark secret of axillary, which we need to publish, is that if you're going to have use the axillary for a prolonged amount of time, and I say prolonged beyond 72 hours, and you know that up front that it looks like it's going to be a long one. I used to think that this was going to be a great access point for heart failure patients, and because they get to ambulate, sit up, and so forth. But what I find is exactly what happened in your case happened to mine. And the surgeons actually, when they do the cut down and put a graft on there and sew it on there, they actually don't have this complication. And, I've talked to McCabe about this. And so I'm going away from doing percutaneous axillary artery access in patients who need it for a long time, because almost inevitably greater than half of these patients have that angiographic finding that came in your case. And so some of the perceived advantages that we thought about axillary as we're starting to get into more and more experience, we're seeing clot in about 72 to 96 hours. So for short duration, I think it's great. If it's going to be in there for a long time, you may want to consider taking it out and having the surgeon cut down the other side. We have 2 cardiac surgeons on here. Have you guys observed that as well? Or do you have any opinion on that? And secondly, I think the way that you dealt with the extravasation was great. One comment I would make is the notion that manual pressure is going to close a 14 French axillary. That's not true. It will buy you time, so you can hold manual pressure, but it's not going to seal it. So you could temporize it just like you did, but if you could have sat there for an hour and it probably would have continued to bleed. So you did the right thing as it relates to the bleeding complication. So those are my comments.
Well, I would say one thing, we definitely go to surgery more on the 5.0s and the 5.5s, but trying to mobilize our OR in a given period of time is an act of God. And so in the patient who was shot, I really, have been fortunate that we have good surgical support, but my concern on him was that there was no way we were going to get the team in fast enough time. So
no, I'm not being critical of that. You did the right thing. It was a time-sensitive shock patient, so you did the absolute right thing. The point I'm making is that, like at 72 to 96 hours, if it looks like the patient's going to need prolonged therapy, you may want to talking to the surgeons and say, hey, I need to get this thing out before it becomes a problem, and see if you get the surgeons to help you cut down on the other side. But I absolutely agree with you. In time-sensitive situations, middle of the night, mobilizing an operating room, a cardiac surgeon, anesthesia, logistically is a nightmare and does not happen even at the most, at the ivory towers of medicine. I'll just leave it at that. It still doesn't happen.
Other comments?
Jamil, Dr. Huey had a question.
Yeah, let me read Dr. Huey's question, please. Dr. Huey is a new surgeon here at the University of Texas Health Science Center here. She's stating that Dr. McCabe has published in the 2019 JACC Interventions data from the STS-TVT registry comparing TransEct with transapical direct aortic, showing concerning higher stroke rate of 6.3% versus 3.1% for TransEct, which is different from your excellent outcome. What is different from your excellent outcomes?
Yeah. So okay, that's a great question, and it's a common question. So, so the McCabe paper, it is true we were above 6% in patients who had axillary artery. The limitations of that, it's number one, it's a registry. There was tremendous amount of confounders, and there's no causation or correlation that we could prove. You got to keep in mind, if you're getting a percutaneous axillary transcatheter aortic valve, it's because you're likely a vasculopath. There's for some good reason. So those patients are definitely higher risk patients. The question we need to ask ourselves is, in the patients that need alternative access for TAVR, what is the safest approach? And I'm starting to believe, based on the data, that it's possible that transcarotid cut down by a surgeon who knows what they're doing and does a lot of these seems to be the lowest, counterintuitive to what I would have ever believed, but it seems to be associated with the lowest stroke risk. But the problem with that approach is, for example, at my institution, the surgeons don't do that. We've never done one. Our stroke rates with axillary is very low, but again, we have good operators who have done it for a long time. So I think it's something that's important. It's a signal that is concerning, but I would keep in mind that, you know, there's a lot of confounders. The right side versus left side axillary was not reported. And again, the limitations that we all know about registries apply here, but the signal is concerning. And again, I think we need to decide what's the safest one, and I think it's going to take time to figure that out. But I think direct carotid is promising. That's kind of my observation of the limited data that we have.
Fantastic. The panelists are. Do any of you have any comments? We've now completed our 3 cases.
Yeah. So oh, sorry.
So if you can use a sentinel, I mean, if you want to use a sentinel via the radial access, does that sort of exclude axillary access as an option for you?
No, that's a good point. And, you know, that's exactly what we're talking about at our program. If somebody needs alternative access given this signal, and our default alternative in our TAVR program happens to be percutaneous axillary, if the left side is suitable, then we would use, you know, sentinel on the right. But, you know, for those of you that use sentinel, the way it's designed, you have to use it from the right radial. So if if left percutaneous axillary is not an option, and you have to go from the right, then you can't protect those patients. The other thing as it relates to sentinel, you know, I believe in sentinel, although the data, you know, looking at hard endpoints doesn't justify the utilization. At my institution, we're having tremendous challenges trying to convince administration because of the cost it's cost prohibitive in our TAVR program. So we have to be very selective, and I'm not sure anyone knows who is truly a high-risk stroke patient. So we're reserving it for young patients, for bicuspid valves. And, you know, I don't know if that's the right thing to do, but we're trying to make sense of it all. I don't know. Some people use it 100% of the time, which makes sense to me, but that's cost prohibitive at most institutions.
Just a couple things. One, the left side is always going to be, we know from carotid stenting, the left side is always going to be higher stroke risk because the left side subclavian and left access side is always more stenotic. And these are people with real atherosclerotic disease. And so I would say, you know, like you said in the very beginning, go right if you can. And then I think speaking to stroke, and maybe just kind of my overall question for you from the beginning was, how are you anticoagulating them and how much? Because I think it's a lot, right?
Yeah. We, for anybody who has we actually adhere to the same recommendations for ACT target and Impella as indwelling in the axillary, and we target ACTs at 180 to 200. We have been very fortunate where we haven't had any, bleeding complications relates to stroke. We have had one very bad stroke on a Impella axillary case that was catastrophic, MCA stroke on one of my colleagues had. And so I think we have to be cognizant of the fact, and that patient was a high-risk patient, turned down for surgery. He had occluded distal abdominal aorta and had a complication, basically thrombosis subclavian, and showered the MCA. So, it's not a benign procedure. But again, what I would tell people is, if you need an axillary access, it's probably for a good reason. You probably don't have many options, and the patient has a lot of comorbid conditions and is very sick. So it's like anything else that we do.
I have a question for you, Dr. Khaki. This is Chris Pickett. We talked earlier and you kind of alluded to it just a moment ago about carotid access. Having done a couple of these, they're very elegant. And I have been trying to conjure through my brain how one could do a percutaneous carotid access. And I don't know if that's something you've thought about. I mean, definitely the surgical access is very elegant. The IJ always seems to be in the way for the surgeon and he moves it out of the way. But it's just, I didn't know if you'd thought about that at all.
I thought about it. The problem I have with, going on that adventure, I like trying new stuff and innovating and doing stuff that's minimally invasive and percutaneously. The problem I see with that is that the surgeons, I've seen a couple of them done, and they do such a good job, and their stroke rate is almost zero. It's hard for us to justify the first few attempts of this. And so I personally would not be the one to take on that adventure, especially with the outcomes I'm seeing from our surgical colleagues. And to your point, it's very elegant. They could do it under local anesthesia. They have tremendous control of the vessel, and they do a great job. So I'm not sure that that's going to ever be an unmet need for us. So
I actually have a comment about percutaneous carotid. I think there was a paper from Europe about transcarotid TAVR, and they used percutaneous access with serial dilation, and they had a stroke rate close to 6 to 7%. So the cut down, I think it's probably a better technique. I actually had the opportunity to train with Keith Allen as one of the surgeons that pioneered that. Transcarotid TAVRs. We did 4 of them in one day, at some point. So, it's a very elegant. We had maybe 1 stroke the whole year. It's the percutaneous access in the carotid with serial dilation, the risk of dissection, the risk of some uncontrolled complication may be higher.
Yeah, he's a guy who convinced me I debated him on alternative access at TVT maybe in 2018 or 19. And if you believe his data, and I have no reason not to, I conceded, that's a better approach if you have a surgeon like him who knows what they're doing. And from a technical perspective, I'm not a cardiac surgeon. I don't know how hard it is and what the learning curve is, but based on his data and his experience, it's going to be hard to challenge that as an alternative.
Well, I as a surgeon, I kind of looked at transcarotid access as alternative for TAVR, like I did the TAVR procedure to start with, which was that this is a procedure that shouldn't work. We're going to give people strokes. This is a terrible idea. What are these people in France thinking? And well, it turns out here we are. And but they also gave a great multiple series in Europe with carotid access for TAVR, and so we started doing that. It's really an easier surgical access even than an axillary cut down. It's an easier access even than a femoral cut down in many cases, because even in an obese patient, access to the neck is easier. Can be done proximally. It's a small incision, even smaller than would do with a carotid endarterectomy, and you have total control of it. Can back bleed the carotid and really kind of make sure that there's essentially no possibility of getting embolization. We have a look at it on our TAVR CT scan, so if you're going to get in a clean artery. It's also more forgiving blood vessel than the axillary artery is, and tends to be as large or even larger than a common femoral.
That's fascinating.
Other comments? Okay, well, I want to personally thank you, Amir, for doing this, taking time from your family and your practice to really help us pursue this, help to make us better cardiologists in San Antonio. You actually had at one point 32 interventional cardiologists on board watching this across the city, Austin, and the Valley of Texas. So you ought to be happy with that. That's something that often doesn't even happen at the national meetings. With that, I'm going to close the meeting. Again, thank you profusely. I want to thank both our members of the committee, our members who sat on the panel tonight, our case presentators. These were all very, very important cases, and this San Antonio Interventional Forum has created an opportunity for us to share cases, talk about cases in a safe environment across different institutions and different medical systems. And it's been really a nice thing for us to have in San Antonio. We hope that we get you back at some point in time.
I'd love to. You should, I just want to say I commend all of you guys. And, I heard about SAFE a few years ago and actually inspired us to do the same thing. And we started the Detroit Cardiovascular Society in the same vein as SAFE. So we appreciate you guys' leadership and, we're all in this together. We're all colleagues trying to take care of patients. So thank you guys so much for having me. It's humbled and honored to be a part of it. And if anyone's in Detroit, yeah, give me a call. I'll take you to some good Middle Eastern food.
Outstanding. Outstanding. All right. with
Thanks,
that being
Amir.
said-
Tremendous.
Thank you.
Thanks, Jamil.
All right, last comments. I'm cutting us off.